A 74-year-old man walked into my office on a Tuesday morning. Harold, retired civil engineer, meticulous man, the kind who tracked his blood pressure every single day in a notebook with columns and dates. He had been doing that for 11 years. He came in because his left shoulder had been aching for 3 weeks. He assumed he had slept on it wrong. His wife had assumed the same thing. They were not worried. Harold was not worried. He was 4 weeks away from a major heart attack. Let me tell you what Harold's body had been telling him for an entire month before that, and why neither he, nor his wife, nor his regular physician caught a single sign. I am Dr. Anthony Miles, cardiovascular surgeon. Over 20 years in clinical practice, and I have had this exact conversation more times than I want to count, with patients who did everything right and still got blindsided. Today, I am going to walk you through the 5 warning signals the body sends in the 30 days before a cardiac event. By the end of this video, you will know what Harold eventually learned, and you will know what to do with that information. But first, I need to explain something about why these signals are so easy to miss after 60. Because this is not about being careless. It is about biology, and about how the aging cardiovascular system communicates distress differently than a younger one. Think of your coronary arteries as a river system that has been running for 7 decades. Over time, the banks narrow. The current has to push harder to move the same volume of water through. That increased pressure, the reduced flexibility of the vessel walls, the small plaques that build up like silt, all of it means the heart is working harder while delivering less. And when that river system starts to fail, the warning signals do not always come from where you expect them.
They come from the edges, from the periphery, from places most people, and many physicians in a 7-minute appointment, never think to look. That is what makes the 30-day window so critical and so invisible. Here is the first signal, and it is the one that gets dismissed more than any other. Unexplained fatigue, not tiredness, but a specific, penetrating exhaustion that does not respond to sleep. Harold had been experiencing this for 6 weeks before his appointment, but he had chalked it up to age. That is an extraordinarily common mistake. A 2020 study published in the European Heart Journal followed 567 adults over the age of 65 who had experienced a confirmed myocardial infarction, a heart attack. 71% of them reported unusual fatigue in the 4 weeks prior. Not chest pain, not shortness of breath, fatigue. The mechanism is direct. When coronary blood flow is compromised, the heart muscle itself becomes oxygen deprived. The body compensates by diverting blood away from the muscles of the limbs and toward vital organs. The result is a systemic energy collapse that feels like aging, not like cardiac disease. The specific character of this fatigue matters. It is present after a full night of sleep. It worsens with minor exertion, climbing a single flight of stairs, walking to the mailbox. It does not improve with rest. If you have been experiencing fatigue with those 3 characteristics for more than 2 weeks, I want you to write that in the comments right now, because that is the exact profile I ask every patient about. Does rest help it? That single question separates normal fatigue from cardiac fatigue in a way that matters clinically. The second signal is one I have spent years trying to get primary care physicians to screen for more aggressively. Sleep disruption, specifically waking between 2 and 4 in the morning with a vague sense of unease. Not anxiety, not a nightmare, not needing to use the restroom. A specific, purposeless waking that leaves the patient unable to return to sleep. The vagus nerve, the nerve that connects the brain to the heart, becomes hyperactivated under chronic cardiac stress. That activation peaks in the pre-dawn hours when cortisol is at its lowest and the parasympathetic nervous system is most dominant. A 2022 paper in the Journal of the American College of Cardiology found that patients who reported fragmented sleep with nocturnal awakening had a 34% higher rate of major cardiovascular events over a 3-year follow-up period when compared to matched controls who slept normally. Harold told me, when I asked directly, that he had been waking at around 3 a.m. almost every night for a month. He had not mentioned it because he did not see how it was relevant. "What time did you wake up last night?" I ask every patient that question. Not every physician does. If you have been waking in that window consistently, without a clear reason, please write down when it started. Stay with me. Because the third signal is the one that sends the most patients down the wrong diagnostic path. Jaw, neck, or upper back discomfort. Not pain, discomfort. A dull ache, a heaviness, sometimes a sensation of pressure that patients describe as feeling like a tight collar. The referred pain pathways from the heart travel through the same spinal segments that carry sensory signals from the jaw, the left shoulder, the upper back, and the neck. Harold's left shoulder ache was not a rotator cuff issue. It was his heart. The problem is that this signal is so anatomically removed from the chest that both patients and clinicians consistently attribute it to musculoskeletal causes, arthritis, tension, and old injury. A 2019 study in Circulation reviewed the presenting complaints of 1,143 patients admitted for acute coronary syndrome. 44% reported jaw, neck, or upper back discomfort as a primary symptom. Not chest pain, not left arm pain. Upper body discomfort that had been present and worsening for weeks prior to the acute event. If you have any upper body discomfort right now that has been present for more than 10 days and you cannot trace it to a specific physical cause, a fall, a strain, a known arthritis flare, I want you to hear this clearly. That is worth a conversation with your physician today. Not next month. Items 4 and 5. That is where this gets complicated. Item 4 involves something I see accelerate cardiac decline in patients who are doing everything else correctly. And item 5 involves a pattern I used to dismiss entirely until the data made me stop dismissing it. Stay with me. The fourth signal is one of the most counterintuitive findings in recent cardiac research. A sudden, unexplained improvement in energy or mood in the 48 to 72 hours before a cardiac event. This is called the pre-infarction syndrome, and it has been documented in enough patients now that it deserves far more public awareness than it receives. The proposed mechanism involves a surge of catecholamines, stress hormones, specifically epinephrine, that the body releases as a compensatory response to the failing cardiac muscle. Patients describe suddenly feeling better after weeks of fatigue. Some describe it as feeling almost normal again. They assume they have turned a corner. In reality, what is happening is a physiological last stand. A 2021 case series in the American Journal of Cardiology reviewed 74 patients who had reported this pre-event surge to family members before their cardiac event. The authors described it as a documented but poorly understood phenomenon that warranted prospective study. I tell every patient now, if you have been exhausted for weeks and then suddenly feel inexplicably better, do not go home and mow the lawn. Call your doctor. That improvement is not always good news. And now item 5. This one is the hardest for me to talk about because I made this mistake myself. For years, I told patients that heartburn, indigestion, and nausea were not cardiac symptoms unless they were accompanied by chest pain. I repeated what I had been taught. I told patients that acid reflux was acid reflux, that nausea was a gastrointestinal issue. And for years, that guidance cost some of my patients time that mattered. The vagus nerve, the same nerve I mentioned earlier, innervates both the heart and the entire gastrointestinal system. When the heart is under ischemic stress, that shared nerve pathway produces gastrointestinal symptoms that are functionally indistinguishable from reflux or a stomach upset. A 2023 meta-analysis published in JAMA Internal Medicine analyzed 22 studies and found that gastrointestinal symptoms, nausea, epigastric discomfort, indigestion, were present in 39% of confirmed cardiac events in adults over 65. 39%. I stopped giving that old guidance in 2018. If you are experiencing new or worsening nausea or indigestion, especially in combination with any of the other 4 signals I have described today, that combination warrants a medical evaluation, not a bottle of antacids. Here is what I really want you to understand. Every single signal I have described today connects to one underlying mechanism: reduced perfusion, insufficient blood flow to tissues that are not getting what they need. The fatigue is reduced perfusion to muscles. The sleep disruption is the nervous system responding to chronic cardiac stress. The referred pain is the same compromised circulation expressing itself along distant nerve pathways. The gastrointestinal symptoms are the vagus nerve under continuous strain. When you understand that one thread, the signals stop looking random. They form a pattern. Harold came back 6 weeks after that appointment, after an echocardiogram, a stress test, and ultimately a cardiac catheterization that revealed a 78% blockage in his left anterior descending artery. We intervened. Harold went home. He is 75 now, still logging his blood pressure numbers in that notebook. He told me last spring that the shoulder pain is gone. I told him that is because we fixed the problem it was pointing to. Now here is what you need to do with this information. First, write down any symptom from this list that you are currently experiencing, with the date it started and a description of how it feels. Specificity matters when you talk to a physician. Second, if you are experiencing 2 or more of these signals simultaneously, call your physician's office this week, not to report an emergency, but to request a cardiovascular review. Use these exact words. I have been experiencing symptoms that I believe may be cardiac in origin, and I would like to schedule an evaluation that includes an EKG and a discussion of my risk factors. Third, if you have a history of coronary artery disease, hypertension, or diabetes, and you are experiencing any of these signals, you may also want to ask specifically about a C-reactive protein test, which measures systemic inflammation and has been increasingly used as a pre-event risk marker. A CRP level above 3.0 milligrams per liter is associated with significantly elevated cardiovascular risk. Before making any changes to your medications or supplements based on what I have described today, please have that conversation with your physician first, especially if you are currently managing hypertension, diabetes, or a known arrhythmia. What I am giving you today is the information to walk into that appointment with confidence, not to replace the appointment itself. This is not a video about fear. I want to be clear about that. Harold did not need to be afraid. He needed to know what to listen for. You are 30 days ahead of Harold right now, because you have this information, and he did not then. You are not too old to act on this. You are not past the point where any of this matters. What you are is informed, and that is where everything starts. If you are going to bring this list of 5 signals to your next doctor's appointment, comment "doing this" below. If you know someone over 60 who needs to hear what I just described, comment "sharing." I read every single comment on this channel. I release a new video every week, built around the conversations your doctor does not have time to have in a 7-minute appointment. If that is worth your time, I would be grateful for your subscription. I am Dr. Anthony Miles. Take care of your heart, and I will see you next week.